At the onset, I would like to say that this is not a study done by me alone. It's a study done by our Regional Resource Center, the whole team. Without their contribution, this study cannot be completed. The background for this study is that health intricately linked with development, that is also to MDG 4 and 5. Developing countries still struggling with poor indicators, particularly MCH and nutrition. And the MCH is one of the major area of concern in India since independence, and need for improved health service delivery, community ownership, and decentralized processes of planning and action. So NRHM aims at addressing these concerns so as to accelerate achievement of MCH targets. Now, as we all know that Rogi Kalyan Samiti, a key initiative of NRHM in strengthening health delivery systems. It is originated as a committee of people's representatives at a hospital in Indore, Madhya Pradesh, and later adopted in NRHM. RK is committed for the optimal utilization of services, rendering transparency and accountability of the health service providers to community. In West Bengal, this Rogi Kalyan Samiti constituted at PHCs, all PHCs, BPHCs, subdivisional hospitals and district hospitals, also in state medical colleges and state general hospital. And this initiative, it was started in middle of 2006. The members, as we all know, that the members of RKs are from health, administration, PRI, NGO, and IMA. And the funding sources also we know what are the funding sources for this RKs. So the need for the study, why this study? Certain facts emerged from the field visits, common opinion and available reports. From these facts, we understand that extent of the association of the RKs members, particularly from non-health field, with the structure that varies. Common apathy of community members towards utilizing public health facility services, low awareness in community regarding the existence of RKs in the facility service centers, and very few studies on RKs available. So need emerged to understand and explore possibilities in popularizing MCH issues through RKs by collating first-hand field experiences. Significance of this study, that is, the study is nearly an unprecedented attempt in the region to integrate political will to act upon less focused component of NRHM. Brings rural experiences for discussion. It can lend strong voice to urge for improvement of health services and also bringing community closure to the institutional services and substantiate evidences for making health system responsive to community demands, can enhance also geo-NGO partnership. Based on all these concerns and issues and background, so study objectives are set in a way that understand perceptions of constituent members about RKs, analyze functions of RKs with reference to maternal and child health activities, collate the perceptions of users and local community members about institutional health services, like community opinions collected to understand health-seeking practices, particularly MCH from facility centers, and identify the limiting factors of the study. Now the limitations are availability of RKS members, various factors like PRI election, then bird flu outbreak, then busy schedule there, then sample too small to represent the district situation. This is more exploratory than a methodic investigation. Unavailability of documents at some places and very short study period, remotely located study points. The study period was March to August, March to early June in 2008. So the objective one, to understand awareness of RKs among its members. The perception of members, that is according to majority of the members, this platform, it is a platform for public-private partnership and leading to greater transparency in financial dealings, promoting convergence between health and PRI. So perceptions are large and distant without emphasizing our case immediate role in improving service delivery component. Only district level health personnel could refer explicitly to guidelines. Many members not sure about their own roles and responsibilities, comparatively health personnel. They have an idea on their role as signatory. The signatories also, they have some idea. And overall, different representatives from the non-health sectors exhibited a wide range of understanding and involvement with our case. Some members, like civil society representatives like IMA and NGO, they feel that they cannot contribute as discussion mostly on financial matters. Members like nurse and laboratory technicians highlighted constraints on health services like unavailability of medicines, equipment, staff, residential insecurity, but which could not have been resolved through the RKS. At the BPHC and PHC level, none could assertively draw linkage between RKS and improvement in maternal and child health services. So the objective 2, that is analysis of functioning of RKS with reference to MCH activities. Functioning in terms of regularity of monthly meetings. So the meeting is important, very important. Participation is also important as it ensures frequent interaction of members as stage setting for joint action. But as we see in this table, that the number of meeting held and also the participation, it's in some places it is poor. Actually, even then, in one place, that is the district Nadia, the study was restricted in 3 districts. So one district, Nadia, exhibits more number of meetings despite same hardships across the state. And
2 more minutes.
Okay. And the functioning also, that is attendance of BMOH at all level, but less participation of members from non-health sectors, representation of PRI members more at PHC than BPHC, very low participation of civil society members. Then MCH as priority issue functioning, by and large, this issue and activities get less priority in meetings. Overall, MCH issues discussed like JSY availability status and resolutions for purchase of equipment and samples. So quality of services and care for the users are least prioritized in discussion. Functioning of RKS in monitoring, most of the BPH study points are equipped with some instruments, but absence of basic health facilities is a serious issue across the PHC study points. In many places, basic facilities like electricity, hampering cold chain, beds were missing or unclean, thermometer and first aid is dysfunctional for long, security of staff is not there, staff vacancy is a major issue like pharmacist, it's the absence of pharmacist, and rarely OPDs open on time and usually close early. So, some common issues at both, PHC and BPHC level, where serious attention is required like cleanliness, no mechanism to get user feedback, and subsequently grievance redressal systems not functional fully. Poor female privacy during checkup and treatment, poor bed facility. In most places, even minor repair of essential equipment take long time for decision to come down. Regularized monitoring of health services by RKS is rarely practiced. So RKS members can assume a greater responsibility in monitoring, identifying service gaps, reporting and taking action for sustaining health service development. Quality of care and services is also needed. These are some pictures, that is, for some initiatives that's for health improvement, like wall writing, waste disposal management, then safe drinking water facility, then visitors waiting place, some referral map, involvement of NGO in beautification premise beautification, then display of medical services availability, then sick newborn care system and a newly renovated labor room. Now, collate, objective 3 is collate perceptions. Two are here. It is based on the personal experiences and the anecdotes. The personal experience is that for PHC and BPHC, it is good because of medicine available, but because PHC, because it is open every time, and BPHC, okay, to some extent the medicine is available. But again, from anecdote, that mothers and children die most in hospital due to infection from some FGD, and also medicines that is given to PHC are outdated. Our case need to take appropriate action for addressing users' grievance and enhanced practice for seeking healthcare from facility centers. Now, objective 4, the last objective, that is to identify the limiting factors in our case. Lack of adequate information about our case functioning and members' roles among all the members. Often guidelines and related orders are not populated beyond BPHC. Lack of sufficient capacity to handle financial management, delay in fund transfer from higher level, lack of supportive supervision and monitoring, and coordination issues, particularly with NGO, because one member NGO, they didn't know that they are the NGO of that, they are the member of that our case. In one Panchayat Pradhan said, that is, we are given to many different activities to perform. Representing at our case is one of them. If only we had an orientation in it, our performance could have been better. The last one, that is the last one, that's the dialogue for development, translating evidences to policies, a systematic and mandatory orientation of our case members about their roles and scope of activity. Continuous capacity building support to health personnel on health management in realistic terms, like basic security to IPD patients, female privacy, even some basic things also. Similarly, sensitizing PRI representatives on MCH issues in the area, strengthening fund flows and related systems of monitoring, reviewing guidelines in light of evolving experiences, and especially providing space to NGOs and ASHAs to actively participate in RKS, and linking RKS meeting at PHC with 4th Saturday and other village level meetings. Putting in place grievance redressal and feedback mechanism, and strengthening monitoring mechanism, particularly regularized monitoring from district and block health level. Thank you.
Sorry to have hurried you. I'm sure some questions will be there later. So
only one point, that is this.
Selected for the VHSs under CM was VHSs were at least 3 months old, and they were structured as per NRHM guideline. Members were trained under CM processes.